Good afternoon, everyone. Welcome to the 12th edition of the Teach Educational Rounds, Complex Client Journey Part 2, with our faculty today, Rosa Dragonetti and Alexandra Andric. If you're interested in obtaining a letter of completion for today's Teach Educational Rounds, please make sure that you had registered for the webinar and completed the pre-learning assessment. You must be signed in with your first and last name and complete the evaluation and post-learning assessment sent after today's session. These webinars are being live tweeted on Twitter. Follow CAMH Nicotine Dependent Service at PS Quit Smoking. And to follow the live tweeting or to post your questions or comments using Twitter, follow #TeachWebinar. These are our bios for Rosa Dragonetti. Oops. Rosa is the Project Director of Addiction Research and Education at CAMH and plays a key role in developing a strategy for education research and program initiatives, including the TEACH project. Alexandra Andric is a registered nurse who has worked at CAMH since 2006 and has worked in a variety of psychiatric settings such as the General Psychiatric Program and Addiction Medicine Clinic. Here are our disclosures, our faculty disclosures. The TEACH curriculum and slides were developed and compiled with funding from the Government of Ontario, Ministry of Health and Long-Term Care. Content of slides are primarily based on evidence-based guidelines from the following sources. These materials, as well as the verbal presentation and any discussions, set out only general principles and approaches and do not replace the need for individualized care. So just want to catch everyone up. We have done a two-part series of the Complex Client Journey. Our first series was in January, where we followed a case that was submitted by one of our participants. And we discussed treatment options that we can apply for this client. Today's webinar is going to look at the techniques and strategies that we had suggested in that webinar and what the follow-up was with this particular client. So just before we get started, we're going to do a few polling questions. So please indicate what type of organization you work for. So it looks like family health team and hospitals are our two top. Okay, great. And please let us know what your current discipline is. You may need to scroll down on the page. Now, if your discipline does not show up in the list, please do write that into the chat box for us. So it looks like the majority are registered nurses. Great. And last one. Please let us know what organization what region your organization serves. It looks like majority are from Eastern Ontario. Thank you. Thank you, everyone. So I will hand it over to Rosa and Alex to take us through today's webinar.
Okay, thanks, Parizad, and welcome, everyone. to the second part of the webinar. So just to recap, to make sure that we're all remembering what the case was about, I'll just kind of go through a little bit of a history. So we were talking about a 69-year-old female. She's a retired psychiatric nurse, and she's currently living in the basement of her daughter's house, and also living with her grandson, who's 7 years old. She smokes 10 to 24 cigarettes per day and does smoke inside the home. She has COPD and a chronic cough. Also has some generalized anxiety, possible depression, although undiagnosed, osteoporosis. She is severely underweight, and she initially started smoking to lose weight. She does have a fear of gaining back the weight, so this could be a potential barrier of her quitting smoking. But according to the dietitian, no concern of eating disorders. To date, she's been averse to all quitting smoking cessation medications. She reports having a negative prior experience with these medications. She is seen by a psychologist and is receiving CBT. She also sees a dietitian and the lung health nurse, so she does have quite a bit of support. So she presented because she was having difficulty breathing, and she's part of a pulmonary rehab program. Some of her chief complaints: lacks energy, can't cook or get out of the basement to get to the kitchen. She drinks large amounts of black coffee. Believes that her daughter doesn't take her illness, her COPD, seriously, and claims to smoke to get back at the daughter, calling it a slow suicide. So you can see that there's also some personality issues here. She's on medications for her COPD, something for her reflex as well. Again, she's had some adverse reactions to smoking cessation medication, so bad side effects with Champix. Her doctor won't prescribe Zyban for some reason. She says this is because of the side effects. We're not really sure. And although the Joanne and her team are able to provide free nicotine patches and gum, which she's accessed, she says they don't agree with her either. So that's not an option for her. So some of the main issues that we had talked about was, does she really want to quit? What can we do to get her past her excuses? How can we make quitting easier when she refuses all medication? And the only positive is that she comes to appointments but seems to just want lots of attention and goes off on tangents to avoid the actual topic of quitting smoking. So these are some of the things that we had spoken about. Before we go on, Joanne, I don't know if there's anything to add to this, since you've been seeing her weekly. Anything change, any progress made? So if you want to maybe just type in some of the comments to get us up to speed in terms of what's the current state with this client.
Okay, I unmuted myself, so should I just talk?
Perfect.
Okay. All right, that's faster than typing. We did see the client again in mid-February, and the dietitian who is here today, April, and I met with her, and we kind of just laid it on the line, and as you guys suggested, we said, you know what, we feel bad, we don't seem to be helping you, you're not moving ahead at all. So we sort of said we're not really sure what the point is, but we did ask, is there anything we can do to help you? And she replied with the strange comment, we could get her a new daughter. So obviously nothing we can do in that area. So in the end, then we saw her again on March 10th, so just a couple of weeks ago, and she's increased her smoking consumption again. She refuses to use the patch. I suggested maybe we cut off the adhesive and gauze it onto her arm with tightly wound gauze. And she said, no, she's deathly afraid of the patch, although not deathly afraid of smoking. So we tried to circumvent the allergy part, but she said she'd like to think about that for another month. She did bring her granddaughter to the appointment with the psychologist, which was odd, but in the end that actually worked out well. The granddaughter's 18, and they seem to have a nice, warm relationship, and they kind of both vented about the person in between, which is the granddaughter's mother, and our patient's daughter. So they are going to continue maybe to see each other with the two of them there. We tried to give her the psychologist tried to give her some exercises to practice meditation and relaxation. Her excuse was that she didn't know how to use a computer, but the granddaughter will help her with that. And she did say that cigarettes are the only thing she has control over, so she really hates to give them up. And I did suggest that quitting can give a person a good sense of freedom and control, but she didn't really respond to that at all. So for the moment, she's going to continue seeing the psychologist. She's going to weigh in with the dietitian when she has those appointments just to make sure she doesn't drop any weight. She's very, very frail. And she told us in her past she weighed 300 pounds. This is before any of us knew her, so we're not totally sure if that's accurate. But she lives in fear of regaining that weight, although we try to assure her that that would be a slow process and we would catch it. But she's insistent that if she quits smoking, she will gain a couple hundred pounds. So she's just going to weigh in, and then as far as the smoking, she's just going to get back to me when she feels that she's ready to quit, because she agrees that she's just not ready. So that's where we stand now. But she did make an appointment with me for April, and I said, why does that mean you are going to reconsider in April? And she said no. So again, she's seeming to just want appointments. And she'll also weigh in at that time and see the psychologist. But she definitely likes to check in with our whole team.
Okay. So
that's about it.
Yeah, thanks, Joanne. I think that really helps quite a bit, and I think it's pretty consistent with some of the strategies that we had talked about during the first webinar. And one of the questions that came up was really about her readiness. And based on what you told us today, it's pretty clear that her primary focus right now is not on quitting smoking. Although there's a lot of things that you said that I'd love to talk about at some point. But before Alex and I weigh in, we want to hear from other people. And in terms of what your impressions are at this point, these are just some of the questions that you might consider, but what would you consider at this point with this client? So she is coming back in April, and although she says, I'm not going to be ready at that time either, this could be an opportunity to re-engage her in some way, or I don't know what you might do, but maybe we can put it out to the group right now, and what are some things that kind of strike you right now about where this client has landed? So Natasha says that a lot of seniors seem to be afraid or nervous about the NRT, and we do see that, right? Yeah.
We see that with like a lot of clients who come into the clinic, and it's really using that EPE, like eliciting from the clients their thoughts, their concerns, providing a bit of information, and then seeing how that sits with them. And when I think about this client that Joanne shared, there's a lot of trepidation, and I feel like Joanne has made a good effort to try to give her some information, but she just does not want to go there, and she doesn't want to quit. And I think at that point, you gotta let it go.
And that's the hard part, I think, for us is to let it go, because, let's face it, this woman has COPD, and she's got some mental health issues, so you know how important quitting smoking would be. So I guess that's where the pressure from us comes from to really help her. But I think, Joanne, the way I heard you describe the update of the case is, as soon as you asked her or reflected back to her, it's like, don't know what else to do for you, then she kind of says, yeah, I'm not really ready. And that can be hard to hear sometimes, but so I'm just looking at some of the comments. You can lead a horse to water, but that's for sure. That's exactly what our job is, to lead the horse to the water, but we're not really in a position to force them to do anything. Harm reduction. So, and Joanne, maybe you can comment on this. Has that been explored? So, not necessarily quitting, but could she reduce the amount that she's smoking, smoke outside, making some of these smaller changes? I don't know if that's been tried with her.
I have a feeling there was something that prevented her from going outside, but I don't know if it was an energy thing or she talked about I would crawl up the stairs if they were up the stairs to get the cigarette or something like that.
The stairs, she gets out of breath.
Yeah.
Yeah, which again is related back to her smoking. So we know all the good reasons. Yeah, so she has gone up and down, but never stays at the lower level. I think she needs to develop a small circle of friends for socialization and look at other food management ideas such as food for energy. The social piece is really important, I think, because we've heard her, she comes in, she likes to come to the appointments, and it sounds like she keeps the appointments. She is pretty isolated and lonely, and that could be one of the reasons why she keeps staying, why she's engaged. She can't afford Meals on Wheels.
And I know she wasn't interested in someone coming in to give her some help at the home either. And then I also think, just to tack on what you said about the social piece, it's interesting when Joanne kind of gave us an update of what's happened recently, and when she was asked, like, how could we help you, her response was, we'll get a new daughter.
Yeah.
So very difficult, very difficult.
Just looking at another is okay to come alongside and meeting her where she is, then plan for MI at each visit opportunity. I think that's perfectly okay. Is there any limitation to the number of visits she can make to the clinic? Actually, that's a question that both Alex and I kind of discussed, is, some of us can work in clinics where you can see clients forever and ever and there is no limit, but that's not the reality for most of us. And so, maybe by putting those limits around the treatment plan might actually help spark something in her, or it might just kind of say, okay, we need to take a break now because you've reached your limit. So, I think Alex and I have kind of flagged that as an issue, and we're going to talk a little bit about, how do you manage that, because I think it is important.
And then even talking about the way you reflect things, we talk about that in the slide deck as well, so I think that's an important piece as well.
So she has friends, but out of town. She refuses intervention in her home, i.e. home care assessment. So she really puts up a lot of obstacles for the healthcare providers. The medications are really, really bad. I can't do that. So you can't, she ties your hands in that perspective. She doesn't want to reduce. She doesn't want home care. So a lot of things that you're offering her, she's kind of just saying, nope, that's not going to work. And, last time we did talk about how that's a sign of ambivalence.
Yeah. So. And it's interesting what Helene put here, cannot provide her with a new daughter, but how about exploring other living arrangements, retirement residence where she could have companionship? And I wonder, Joanne, you talked about, is the granddaughter going to be living with her in the basement or upstairs?
Granddaughter in basement, so she's going to be living with her.
Yeah, so I wonder if that could be in that April meeting, like a possible in, because the value, like maybe she would want to expose her granddaughter who has chosen to live with her, who they have a good relationship. Maybe that could be something that they could work together on, just like reducing or something.
Yeah,
maybe.
Absolutely. I mean, that if she does have a good relationship with her granddaughter, then maybe that's where some of the motivation might come from. So that would be something to explore. And I'm seeing lots of comments about the providers working harder than the client, and I think we kind of agreed on that, right? Going back to the whole offering her the retirement residence, that might be a good next step, right? So if things don't work out with the granddaughter, which is a possibility, then, she does have some choices. Although I'm just anticipating that she's going to not want to go to a retirement home.
Yeah. And it says here, Joanne mentioned that it's tied up in the home, so she's helping out her daughter.
Where she lives with her. Okay, so money is an issue.
And then she wouldn't want to go anywhere else because it would be abandoning the young grandson. So.
Yeah, so you don't have the opportunity to offer groups, but I'm wondering if there are other programs in your community, maybe through public health or other agencies where they do have groups. So I think that is a good, because sometimes, you know, as a lot of you know, when clients hear it from other clients, they're actually more receptive to some of the suggestions.
Yeah, and I totally agree with Rosa, and there's someone I'm working with currently where that's the way it works. And I do not, I mean, it's great when you don't talk a lot in the session, but I'm very, very quiet and reflective in our sessions, because if I say anything, it will be like, what do you mean?
Yeah.
I don't know. I got to do it my way. I'm like, okay. So I think that's really important, the idea of a group, because the group has advised her to try the patch, and they're the reason why she tried the patch.
Yeah. See, so, because, you know, the whole, going back to the fear about using the NRT, which I can't remember, Joanne, how much you explored that. Like, what exactly is her fear? Is it mostly around the allergy portion, which is not dangerous? It could be uncomfortable. So how much education was provided in terms of the patch, and, you know, what exactly are her fears around that? Because, you know, as everybody here knows, it's much safer than smoking. So, you know, my suspicion is it's her ambivalence coming through, and it's an excuse. Yeah. But, you know, again, the more we talk about kind of breaking down some of these, you know, fears and ambivalence, then maybe it's a better way, easier to engage her. Yeah, the dog thing, I saw that, and Elizabeth's making this, if her dog is important, perhaps she would respond to the long-term health of the pet. Many of you have already probably heard that we have a pet board in our clinic, because pets are very important to some of our clients who are isolated, and their pets are the only family that they have access to, and people do come in to quit because of the effects on their pets. So, and her grandson who has asthma, that's a really important piece. Lots of really, really good ideas. If people are typing, we'll just kind of give them a minute. And the other thing is that you say she's not really good with the computer, but if her granddaughter helps her Smokers Helpline online, that might just give her, you know, because it's fairly, you know, self-directed, right? So she doesn't have to engage with anybody particularly. It's an online program, but she can still have, you know, the smoking cessation
floating in her head.
Yeah, that's what I was kind of getting at. So, you know, maybe her granddaughter can help with accessing that. I mean, it's really easy to use. So. Or, you know, if she prefers, she can call them, you know, and they can have the conversation about the, you know, different strategies, but also, again, helping with her ambivalence. Yeah. Maybe look at what she really enjoys about smoking, and also make her aware of the second and third hand smoke. Quit lines and social groups. Absolutely. So, and Joanna, I made the assumption, but maybe you can elaborate. Have you done sort of a pros and cons with her in terms of, you know, the pros of quitting versus the pros of continuing to smoke, and the cons, and have you done the decisional balance?
And I think someone earlier said coming alongside, so, you know, exploring the good things first about smoking, and maybe the not so good things.
have talked about that, but maybe a good idea to write it down for her and start over in
Yeah.
April. Yeah, actually, that's a good idea. And well, you haven't seen her. You're not going to see her before April, but sometimes you can give clients homework to do, and to have them complete that exercise while they're away from you, and then come back and review it. So, you know, what did you identify as some of the benefits, and what are some of the not so good things, and but yeah, so maybe in April they can pick that up.
And I think even at that time too, if, you know, just to tack on to what you said, like some of her values. So if we know what this person finds very important to them, maybe that could be our in. Like, how does your smoking fit in with this particular value? And that might create that discrepancy. And, you know, she does like seeing you, Joanne, and the people at the clinic. So the rapport is there. So it's probably safe enough to, like, put that on the table and actually say, so, hey, like, help me understand. It kind of doesn't go together with what you value.
Yeah, the developing discrepancy, right, is really important. So, you know, and somebody's saying it right now, so it's important for her to contribute, to help her daughter, to help her grandkids, but how does the smoking fit into all of that, right? Because she can't breathe, she gets tired, so, you know, it is the impact of developing that discrepancy.
And she may have those issues with the daughter in terms of their relationship, but it sounds like she does love her grandson and her and the granddaughter. I mean, I'm sure she loves her daughter too, but they don't. The relationship seems to be a bit better with the younger
with the
people.
Yeah. She's 30 pounds underweight. Yeah, I mean, you know, the fear of gaining weight, it's interesting because a lot of our clients have that fear. And for most of those clients who do have the fear, it's not really, it doesn't come from an eating disordered place. And I know she doesn't have an eating disorder either, but she does have a pretty intense fear. And, you know, telling her that she's not going to, like, the likelihood of her gaining 300 pounds because she quit smoking is probably 0%. She might gain about 10 pounds, which is the average. But 10 pounds might feel very overwhelming to her as well. So I'm not sure just providing that information is going to be helpful. I don't know.
You know, I think it's almost like having a conversation about, okay, so tell me, like this illicit idea where, okay, what are your concerns and how, you know, how are you, I mean, you're not eating now, and but what you're doing is you're using stimulants to provide you the get up and go, and, you know, providing information about eating breakfast actually kickstarts the metabolism, or, you know, if you can graze throughout the day to get what you need. And is there some body dysmorphia going on,
I know,
right?
I wonder.
Yeah, so it's almost like asking the person, okay, what's the deal with your weight? Like, tell me all your concerns. And she must have done other things besides smoking to get rid of 300 pounds, right? Yeah. So she must, you know, what worked for you before. And the people who are the big gainers are people who are emotionally eating, people who don't have support. So looking for those kinds of, like addressing those barriers. So
so Joanne's saying definite body dysmorphia. Yeah. So, you know, one of the things is, I don't know if the psychologist is addressing that, but, you know, incorporating CBT for body dysmorphia would be really important. So, because that's, you know, all this education about the weight gain and you have to gain 100 pounds before you see negative effects, it's not going to make a difference because this is disordered thinking, right? It's not about, you know, we all have concerns about gaining weight and, oh yeah, it's not going to, you know, it's better to quit than to, you know, be 10 pounds lighter. That's not going to work for her. It really has to be specific treatment, I think, to the body dysmorphia.
I agree.
Yeah. And the other thing, Joanne, that I was, and I'm not sure if you said this the last time, is, you know, making sure that everybody she's seeing, because she sees a dietitian, she sees the respiratory therapist, and she's seeing you as well, everyone has that consistent message so that, you know, when she sees a dietitian and she's trying to eat healthy or whatever the work is, how smoking interferes with that, right? And I don't know if your dietitian has access to that information, but there certainly is, Alex does a workshop here about that.
Mm-hmm.
We can share some of that information because, smoking does deplete some of the minerals
Yes.
and vitamins that you need.
Yeah.
The psychologist is attempting CBT, but woman doesn't follow through on homework or suggestions. Yeah, I'm not surprised.
And this is interesting about what Jenna has said about control here. Control over smoking, like smoking is a sense of her control, eating is a sense of her control.
Mm-hmm.
So getting at the root of that, I'm thinking too, which, maybe that's the psychologist might be able to do that, but it's kind of like it's all this root of, there's something deep inside there that is not, that's keeping her in this place, and I'm not really sure.
I know.
It's like a personality
well,
thing.
And not being ready.
And not being ready, those two things.
Because Joanne just commented, yes, we have lately been seeing her as a group, which is ridiculous, but she loves it. So I don't know. I mean, we can't diagnose, and we're not diagnosing. We're not. But the personality disorder feeling is really coming out in this, right? Of course, she's loving the attention that she's getting from, can you imagine this treatment team, almost, and this is not a reflection, but it feels like we're all begging her to try and stop. And we're working really hard to try and do it. And she's just kind of sitting back and saying, nope, that's not going to work. No, that's not going to work. And I'm not doing that. And but she's loving all the attention.
Yeah.
So, I think the psychologist could definitely
shed some light on this.
Shed some light and bring some of the psychologist's expertise in terms of, is there a personality disorder? Not that you can't provide treatment to them, but it might have to be a little bit different, boundaries and structure and limits. Yeah, she does sound like some clients I see who have a personality disorder. Mm-hmm. Oh yeah, I think we're all kind of thinking back to those clients that, this is not very unique, right? We have seen these types of clients, and there's usually a personality disorder that goes with it. Her daughter bought her an e-cigarette. Some problem with that. Need to check with her on what was the issue. I'm not surprised because, again, here's another strategy that may or may not work. We don't know, but there's a problem with that too, right?
Yeah.
So no matter what you suggest, there's going to be a problem with it.
Yeah.
So lots of good comments. Keep them coming in. Maybe we can just kind of go through some of the thoughts that Alex and I kind of had, which a lot of you have already mentioned.
Yes.
So we talked about the creating discrepancies. I don't know if you want to elaborate, Alex.
So we talked about this. So connecting with those values. So what are her core beliefs, values, and how do they fit with the smoking? Or I see that both you and your granddaughter love one another, and you're coming in together, and yet you could be putting her at danger with the smoking inside the home. What do you think of that? Or you don't even say anything. Maybe you just say, yeah. And I'm curious, the strong love. How does the threat of secondhand or third-hand smoke fit with that love? And to say it, you guys already have the engagement there. So, but to say it in a very frank way, very gentle, so it doesn't sound sarcastic. And when you have that rapport, you can do that. Because I remember saying, and I'm not sure if I said this at the last session, I'm not sure if I said, I was working with this client who hadn't been taking his psychiatric medications for 3 months, suicidal, very, very low. His girlfriend had broken up with him. And I said, what do you think about these meds? And he had said, well, I want to be able to take some, be paid for research. And a lot of those research studies, they don't want to be having people taking meds. So I was, in my mind, I was like, oh my goodness, trying to shut down the writing reflex. I said to I just said, so for you, the money is more important than how you feel every day. And then he said, yeah. But the next week he did pick up the medications, but unfortunately, I had to let him know that he's got to start on a lower dose with one of those meds, so I'm back at square one again.
Yeah.
But I was able to say that, and it went well. Like, he didn't get angry. He was just like, it was all very matter of fact. So values, this idea of the grandson and the granddaughter, those are the two things. Or, I think I'll just stop there. Would you want to add anything there?
No, I mean, I think it goes back to the point of, to create discrepancy, you have to have a good relationship, right? I mean, this is all MI stuff that you've all been exposed to. So, and it sounds like Joanne does have a good relationship with her. And so, creating that discrepancy on a lot of different things that she's presented, I think there's lots of examples to work with in this area. Sorry.
So it says here, she's aware of the harm and has expressed that, but still won't act.
Yeah.
We'll try to address. So maybe even putting that out there. So, I noticed that you've talked about how this doesn't sit right with you, and yet you're paralyzed. Right, so, and then see what you get back from that, because essentially she's saying, but then there's no movement, and in that way, you're kind of reflecting that without asking a question.
Yeah.
So I don't know where it would go, but.
Yeah, no, I agree. The other thing, which I think, Joanne, you have kind of done, I think you did at the last session, is to kind of take a break and say, hold on here, what are we doing?
Mm-hmm.
This is what we've been doing so far, and reflect back to her all the work that's gone into this. In a very accurate way, right? So, because you can't say, well, you've tried a medication, because she really hasn't. And then just kind of reviewing, again, what are all the strategies? And then maybe brainstorming ideas, but having her come up with the ideas, right? Because you've seen the pattern where you provide the ideas, she shuts it down. Mm-hmm. She comes up with excuses as to why it can't work. So have her come up with what does she do now? And it's not about ideas for quitting, it's ideas on where do you go from here, right? Somebody mentioned this, but reviewing past successes in any behavior change, so whatever that was, to help reinforce with her the skills that she does have, that she is able to accomplish things. And if it's not behavior change, it's just any successes that she's had in her life, because part of the ambivalence is fear of failure, not being able to do it, not having the skills. So just spending time talking about that. Behavioral experiments. So what we mean by behavioral experiments is, she does have a fear, or she says that's not going to work, but can't provide any rationale for it. Then maybe ask her to, you don't have to quit, or you don't have to make a change, but let's just experiment, see what happens. Just try going without smoking for whatever is realistic, a couple of hours. Let's just see what happens, right? You're experimenting, and then you're going to come back and share the results. There's no commitment. There's no change. It's not about that. It's just trying to get more information. You're afraid of the NRT, put a piece of lozenge in your mouth, use it. Let's see what happens. Reassure her that you're not going to die from it, and she won't get very sick. But let's just see what happens. So all these types of experiments, ideally, if you can elicit from her what she would like to do for these experiments, that's better. Because again, she'll just shoot down everything that you're talking about.
And I think too, those behavioral experiments will challenge any of those thoughts in her mind too, because sometimes thoughts are very old and very hard to change. So this could provide that proof. And I know with some of my clients who are very fearful, to frame it as an experiment was very helpful, because you know what? You never know the result. It's no big deal. You just try, and then it's not there's no judgment or value on it.
Absolutely. And some of the comments about the control. So I think this really helps with that control thing, because in what I've done with some of my clients in the past is, you don't have to make the change. No one's going to tell you what to do. Here's what some behavioral experiments have been done in the past by other clients. They've tried this, they've tried that. those may work for you, but maybe you have other ideas. Giving her the control to choose between the strategies that you suggested versus other things, again, that control piece I think is really important.
So you're honoring the person's autonomy, and you're providing a menu of options that, like as you said, they can pick and choose or brainstorm together.
Yeah, and Mary makes a really good point. I think Joanne agrees, is that she wants control, yet the cigarettes are controlling her. She's not going to see that, right? She's ambivalent. She's scared to quit. So she's not going to be able to acknowledge right now that the cigarettes control her, because she still sees the benefits of smoking.
Yeah.
So I'm not sure how helpful it would be to have that argument. We know it's true, but it doesn't really matter, right?
Well, it's interesting because I think that's like a huge value for this person, is her autonomy.
Yeah.
And so I'm thinking about it, like, could we go with values and then the 4 R's, like, how is it relevant to you? What are the risks and rewards and the roadblocks to making any sort of movement either way? So.
Yeah.
So I don't like that one.
I know.
It's very good.
It's
a good case because it's very difficult.
Yeah.
Right, and this happens to all of us.
The words doing their own research on themselves sometimes encourages them to feel important. Yeah. So again, it's giving them that control, that autonomy, that I'm going to make the decisions, I'm going to research. Absolutely. I'm going to buy her a ticket to Toronto and go to... No, we're not taking any more clients. We have a lot of clients like this. But we appreciate your humor, Joanne.
That's what you need. You need to laugh.
Yeah, oh yeah.
We need to laugh.
Yeah, we're going to talk about that actually. Hypothetical thinking. So this is sometimes, this is called many different things, but one of the strategies, this comes from the brief treatment, I can't remember the term right now. It's, asking the client, if you had a perfect life, what would it look like?
Yeah.
If you had all the control in the world and you could change things, what would that be? And just getting her to talk about that. So smoking may not come into it, or it may. And she may say, well, in a perfect world, I would be able to breathe better, I would have more energy, but I would still be able to smoke. That's telling you that she's loving her smoking and that she doesn't really want to give it up, right? So that's what the hypothetical thinking is about.
And who knows, there may be some change talk that comes out of that, right? Because you're moving outside of the reality, and so that opens that possibility door up.
Yeah, absolutely. The writing reflex, so Alex kind of mentioned it, right? And, I know I'm feeling it right now, all the things I would love to say to this woman and, just to help her make that shift. But, she said last time we talked about this, smoking is the only thing I have control over, and I'd hate to give it up. And so that's really important, the control thing. We've talked about it over and over. So yeah, I think that's really important. Right?
And it's something that we as clinicians have to put at rest. It comes from a good place, but kind of morph it into that idea, well, I'm just going to be a great reflector because I can't change anybody.
Yeah.
So that client has to say it out in the session and convince her own self.
Yeah, absolutely. Yeah. So these are some examples.
Yeah. So when I heard about what happened at the last session, I tried to think of some reflections that might be helpful. So I thought of amplified reflections, and that would be, for you, the only choice you have is to smoke, because that's kind of, you're coming alongside, and maybe the person might say, well, actually, yeah, it's true, or they might say, well, there's other things that I can do that, I have control over.
Yeah.
So you're kind of putting it out there without the sarcasm. And then I thought of double-sided reflection. On the one hand, smoking is your only pleasure, and on the other hand, you keep coming in to discuss how to stop it. Mm-hmm. Right? So kind of seeing what you might get from that, a reflection like that, emphasizing autonomy, And that's that idea of, in the end, it's up to you to decide where you'd like to go from here. So you're throwing it back, because if we're sitting, if there's two chairs and I'm sitting in the change chair, the person's going to sit in the, I'm going to stay the same chair. So really you can, like if I think of, you know, that whole thing with nicotine replacement therapy. Okay, what are some of your concerns? Then I hear those concerns, reflecting back, providing some information. How does that sit with you? And then in the end, it's really up to you to decide whether you want to use it or not. Agreement with a twist: smoking empowers you, and thus you'll continue to do so no matter the cost. So that's kind of I see where you're coming from, and then the little twist there of, and you'll just keep doing that no matter of the consequences, which is her not being able to breathe, not having energy, et cetera, et cetera. So what could happen there? And then you've kind of heard about the running head start with the decisional balance idea. So listening. So if all you're hearing is like, I want to stay the same, then saying, okay, tell me, you know, the good things about your smoking, and then finishing off with, well, what are some of those things that aren't so good about smoking? Because there's got to be something there, I would hope. And then lastly, coming alongside, that's where you're reflecting and inviting the person to consider things in a different light. So there's no other way for you but to smoke, and changing would mean finding new ways to get your power back. Perhaps that's too much right now. Yeah. So once again, so it's kind of, it's all the stuff that we've discussed and putting it back on the client in a respectful, compassionate, empathetic way. And people will receive that information because of that rapport you have and the way you say it. And so I just thought of these like kind of thoughts. I don't know if they might be helpful or not.
Yeah, and the title of this slide is actually, sorry, that's my mistake. It's not writing. This is how you respond to the writing reflex.
Yeah,
so
thank you, Rosa.
Yeah. So I just want to look at Joanne's question. She's when I've tried to come up with solutions or ask her why she continues with behavior, she always says, "You tell me." Is it rude to say no? You tell me back to her? I don't think it is rude. I think we can just again reflect it back to her and say, you know, I've offered you some suggestions, but I can't tell you what to do or what's going to work for you. It's really important for you to be in control and decide what is best for you. So put it back on her. She keeps saying she wants control. Let her be the expert. That's right, in her own lived opinion. So that's, I think it's not rude. Yeah. We talked about reassessing readiness because she really does not feel ready to do this. Then there's also this concept of persistent ambivalence, right? So having reached a decision about change does not necessarily result in her conflict about it. So she comes because she keeps saying, help me quit smoking, but she's really ambivalent. And, you know, in many ways, the more we push her and if we're, you know, using strategies to help her quit when she's still ambivalent, it can make the ambivalence worse. So we have to pay attention to that, and this is maybe a cue for us to back off.
Yeah, yeah.
So how do you respond, right? Acknowledge that and reflect that a client's discomfort, that, you know, I get it, this is very difficult. Normalize that feeling distressed when change is hard, and separate the person's worth from the decision not to change. So, you know, we're still going to provide you care in the other areas if you decide not to quit smoking. You know, this doesn't mean that you're not a good person and, you know, all that kind of stuff. And, sorry, go ahead.
I was just going to say, and those affirmations can be very powerful in helping someone believe that they can change. And so even like, you know, if she comes in and in that April meeting, oh, you know, I'm still in the same place. Well, you know, I appreciate you letting me know where you're at, and that's fine. And, you know, where would you like to go from here?
Yeah, yeah. But we kind of just want to spend the last couple of minutes talking about ourselves now, because, Joanne, it sounds like you've done a lot of good work with this client, and you've used up some of the strategies that we've been talking about. Maybe you've got a few more ideas today that you might try at the next appointment. But one of the things that I think comes up a lot, I know with us in our clinic, but also with some other practitioners we talk to, is our duty to help people, right? And when we can't help them, we take that on and we feel like, well, we're failing them. so we feel this sense of urgency because she has COPD or whatever the issue is, and we also feel it's our obligation to help people. But in the end, if we believe in client-centered care and motivational interviewing, it really is their choice and their right to make whatever decision suits them and to do stuff that they're only ready to do. So, but how do we live with not being able to help people? Because that's why we're here. That's why we went into this, right? So I'll talk a little bit about, because this kind of came up at the very beginning in terms of can you keep seeing her on and on. So we always say that termination starts at the very first session, is letting the client at the beginning know that your time together is limited, unless, like I said, you work in a clinic where you can see people forever, but that doesn't really exist everywhere, is letting them know, we've got 4 sessions together, we've got 10 sessions, whatever it is, and letting them know that, okay, every time they come in, okay, we only have, X number of sessions left. What do we want to talk about today? What do we want to focus on? Setting SMART goals, small, achievable goals. Forget quitting if that's impossible. What else can they do? But the idea of termination scares a lot of practitioners because they feel like, well, if I let this person go, 1, I failed. 2, they're not going to be okay because they're not changing. But the reality is you want to provide them some structure, but again, emphasizing their autonomy means that they can do okay by themselves.
Yeah. And your how you are with that person during the time you're together can help them maybe make a change way later on if they're not ready to do that now. And I think also it's important to state your role, like how you will be helping that person in your role when you're working with that person as well, because sometimes you could get sucked into another area where you're kind of someone's case manager because they can't see their other provider as frequently. So just to be careful of that. And people appreciate that because then they know where they stand, and you can kind of talk about that right at the beginning. So there's not a big difficult thing at the end, and you want to revisit it as your middle time and end time.
Yeah, absolutely. And then the final thought that we talked about was the compassion fatigue, right? Which these are some of the signs, right? When we're working harder than the client, that's a sign that, okay, I'm doing it too much. And if you keep doing that, you are going to burn out. I mean, it's just part of the boundary that we have to set for ourselves, but for our clients as well.
Yes. And I think too, it is very hard, but then people, this is a good role modeling for clients about how to, be respectful and still say, your boundaries. And it doesn't have to be a very distressful time, so it's a good role modeling as well.
Yeah, absolutely. And Joanne, thanks for sharing that. We all feel bad because we dread her visits. For sure, to me that's a sign that says, I need to take care of myself, because if you don't take care of yourself, you're not going to help your client either. So really, really important. And again, how are you going to define success? You kept her engaged for a very long time. That's success in and of itself.
Yes. And that goes back to that idea. The seed you've planted with her now could germinate later on. And as Rosa said, I mean, it's very hard, but I think at the end of the day, in your heart of hearts, you've tried your best with this person, and it's about, if you've really been listening and reflecting, this. It's just hard when people are having a tough time changing, and I could just say I had a client who looked like he had a severe allergic reaction to I don't even know what, and there I was trying to encourage this person for 20 minutes to go see a physician, and I was very worried, but in the end it's okay, if you can't breathe, will you call 911? That was my only in that moment. And so it's kind of in the end, as long as you've covered the things that you really need to cover, and then you just gotta let it go, because the people will come back and will respect you for that.
And I think, given what we've learned about this client, she in a few months, in a couple of years, she might remember Joanne as somebody who didn't force her to do something, who respected her fear and her, a need for control, and say, you know what, that's the person I want to help me now that I'm ready. So, so I think you're doing really good work. Let's see, final thoughts here.
Okay.
Yeah, the personality disorder is, I think, really important to flag because actually, I like that saying. Some ambivalence seeks answers, and some is the defense against the possibility of answers.
Interesting.
I like that,
yeah,
actually.
Yeah.
I don't know how others feel about it, but I like that. Yeah. So those were kind of the thoughts that we had summarized from the last session and after reviewing some of the updates. But Joanne, I think you've got lots of good feedback from some of the other participants as well, and it's pretty consistent with, I think, some of the things that your team has discussed and strategized. So it would be great to hear maybe at the end of next fiscal year how she's doing, and maybe we'll be surprised. And but as everybody knows, change is a process, and sometimes the process can be short, and sometimes it can take a long time. So, oh, I'm so happy. Yeah. So this really helps me to feel eager to see her again.
Yeah, which is
I'm so glad. Okay.
Thank you, everyone, for sharing your thoughts. As once again, all these brains help us figure out how to better work with our clients, and I kind of want to have that last message of, in the end, if you know that you've done your best, that's really important, and just to cut yourself some slack and do that self-care. Otherwise, as Rosa said, you'll be of no help to anyone, and supervision or someone on the team who can give you a hug if needed.
Yes, for sure. Oh gosh. Yes. Just as the client doesn't, is afraid of losing control, we don't control our clients. Yeah. So anyway, Parazak, it's up to you now.
Thank you, Rosa and Alex, for a great session today, and for Joanne for providing the case, and also for keeping us updated with your client. For those of you who are interested in a letter of completion, a link to the evaluation and post-learning assessment will be sent by email today at 4 p.m. Eastern Time. You will have 1 week to complete this post-learning assessment, so that will be Wednesday, March the 29th. And as a reminder, you do need to complete that post-learning assessment in order to receive your letter of completion. If you participated as a group today, or if you sign in as a guest, or you sign in with just your first name or just your last name, please do email us at teach@camh.ca so we can track your participation in today's webinar. Without this information, unfortunately, we will not be sending a post-learning assessment to you to get credit for the webinar. So if you are participating as a group, or if you need to let me know, please do so by 2 p.m. today. So this wraps up our 2016-17 fiscal year webinar series of the Teach Educational Rounds. We will be starting up a whole new series starting in April. Our next session will be on relapse prevention in tobacco dependence treatment, which will take place on Wednesday, April the 12th. Registration is not yet open, but we will be opening it this week, so do look out for one of those lovely emails from us, either through the Teach mailing list or listserv. If you missed the beginning of today's webinar or want to view it again, maybe you're just interested in seeing previous webinars, no problem. All of our webinars are archived on the Teach website at www.teachproject.ca under Teach Educational Rounds, Archive, and Self-Study. Thank you to everyone who attended. I hope you all are staying warm, but enjoy the rest of your week. Thank you.
Bye.
Thank you. Bye.
Bye.